Please let me share. Can you see?
Yep.
Okay, great. Well, thanks. First of all, thank you for the kind invitation, Mehmet. A pleasure to join you online, and congratulations on the great series of educational webinars. You asked me to talk about some aspects of degenerative listhesis and stenosis. Do we decompress? Do we fix? And just to clarify, there's no conflict of interest, no financial disclosures. And I will remind us all that degenerative lumbar listhesis or spondylolisthesis is actually quite a common spinal pathology in the aging population and earlier. There is a debate because surgical treatment algorithms are still subject to controversy. There is variable evidence for decompression and fusion, which you will see in the slides as D+F, decompression and fusion, compared to decompression alone. And on the other hand, there are several now high-quality studies which have attempted to shed light on the outcomes of both treatment strategies, and I'll discuss some of them. I'll give credit to the AO Knowledge Forum Degenerative, within which actually we're discussing this very topic, and there's a document coming out soon. But the aim of this talk is to provide a targeted, short summary of the recent literature and some guarded recommendations. So the methodology behind the paper that's going to come out soon is that the steering committee of the AO Spine Knowledge Forum Degenerative selected 6 key articles. 3 were RCTs, 2 were meta-analysis, and 1 was a cohort study with radiographic analysis. I will dive into the series that we all know. So there's the trials that we all know. The first pair, in fact, was in 2016. So it's been already quite some time since this paper came out from the Boston group. And I will not go into too much detail because we will have time for discussion. But the critique of this is that while this study shows some benefits of decompression and fusion over decompression alone for stable grade 1 listhesis, it came with some important caveats. Decompression and fusion carried a significantly higher morbidity than decompression alone, and decompression and fusion may not necessarily be a good option for comorbid patients. In that trial, the surgeons performed a traditional complete laminectomy with partial medial facetectomies. And currently, it has not been studied whether a less invasive midline sparing technique, such as a laminotomy or bilateral foraminotomies instead of a total laminectomy, could have resulted or may result in lower reoperation rates in the decompression alone option. Thirdly, while the overall reoperation rate for fusion patients was lower, the revisions occur at the adjacent level, again propagating the cycle of adjacent level degeneration and disease. But overall, again, despite the investment in several trials and money, we still need more work to try and home in into the specific surgical factors that can influence the outcomes of either option, so that surgeons would ideally only offer fusion to those who would otherwise develop postoperative instability. So to summarize that paper, the quality of evidence seems to be moderate, even though it's an RCT in a very high impact journal. And it provides a conditional recommendation that compared to laminectomy alone, fusion may be considered in patients with grade 1 sleep for improved physical function. Of note, in each arm, there was about 66 patients. The next article came back to the other one. It is a European study, Scandinavian study, with about 230 or so patients in each arm, addressing a very similar question in a slightly different fashion. This was a heterogeneous patient population. It included patients with and without listhesis. They all had stenosis, but not all had listhesis. The surgical interventions were not standardized. There remained uncertainty about the presence of dynamic instability of foraminal stenosis. This is not clarified in the manuscript. And this study did not fully elucidate the appropriate indications for decompression alone. and the additional morbidity of a fusion may be appropriate for selected patients in whom post-op instability is likely. So that paper was judged to have, again, moderate evidence with a conditional recommendation that those with spinal stenosis with mainly leg pain can undergo a midline sparing decompression surgery and avoid fusion. But also, of course, it showed that both decompression and decompression with fusion are options for those with degenerative listhesis. Now, there is another very interesting study, again from Scandinavia and more recent. This is the Nordsten trial. And in this particular trial, decompression alone was found to be non-inferior to decompression and fusion, with the primary outcome measure of the index ODI reduction at 2 years post-op. The extra strength of this trial is that in last summer in the British Medical Journal, there was the publication of the 5-year results with similar outcomes. In other words, the reported non-inferiority of decompression alone was maintained at 5 years. There was a trend towards improved back pain improvement in the fusion group, which requires further investigation. But overall, the quality of evidence seems to be high in this particular study, and it again gives a conditional recommendation that for those patients with stenosis plus claudication, or indeed radicular symptoms in the presence of listhesis, 3 millimeters on standing radiographs, and midline sparing decompression alone can be given as the first choice. Now, there's a couple more studies to discuss, and this one is a meta-analysis from only last year, decompression alone versus decompression with fusion in stenosis with listhesis. And this systematic review meta-analysis indicated no differences in terms of functional, pain, and clinical outcomes between decompression alone versus decompression and fusion in those with low-grade listhesis at 2 years of follow-up. In addition, decompression alone was associated with reduced blood loss, reduced length of stay, and reduced complications. But on the other hand, the decompression and fusion group was seen to be able to halt the compression of listhesis, and the systematic review found higher rates of post-operative instability in those that had only a decompression. The assessment of the quality of evidence on this was low, and again with a conditional recommendation that decompression alone be considered non-inferior to decompression with fusion as a treatment option for low-grade listhesis with stenosis. However, given the higher progression of listhesis observed in the decompression alone group, it is advised that fusion is considered in those with signs of pre-op instability. There is another meta-analysis, and we all know that we have many systematic reviews, many meta-analyses looking at the same data and not necessarily coming to the same conclusion. So we're going to compare now a different systematic review and meta-analysis. This is again from last year, and the quality of this systematic review is primarily affected by the inclusion of level 4 retrospective cohort studies, in contrast to the previous one, which included only prospective studies. This last one does not clearly differentiate the cause of higher baseline disability in the decompression and fusion cohort. Therefore, it's difficult to generalize its findings. Ideally, fusions would be offered only to those patients for whom the higher morbidity of the fusion operation is justified. Therefore, determining the factors behind that disability, it is still a critical element, which is still indeed needed to be better identified, and therefore it can better inform us in our decision making. The findings support decompression and fusion being offered to those with degenerative listhesis, especially those with greater baseline disability. The quality of the evidence of this meta-analysis was low. Again, a conditional recommendation that both decompression and decompression and fusion are equally considered in those for degenerative listhesis in most patients, but taking care to offer fusion to those with greater baseline disability and back pain. And finally, to throw into the mix the radiographic and radiological data and considerations. We looked at the radiographic predictors of delayed instability after a decompression alone without fusion in those with grade 1 slip. It is now a 10-year-old paper, and this one was a level 4 retrospective study, which showed that significant risk factors for reoperation after decompression alone were the presence of segmental motion more than 1.25 millimeters, a disc height more than 6.5 millimeters, and a facet angle of more than 50 degrees. We often hear these considerations, but they've never actually been studied within the contents of a randomized controlled trial. However, in this particular series, the presence of all those 3 radiographic parameters led to a 75% reoperation rate, whereas the presence of only 1 parameter resulted in a reoperation rate of 40 to 55% approximately. However, small sample size, non-standardized outcomes, therefore generalizability is limited. Again, quality of the evidence seems low, recommendation is conditional, but we do now again find that evaluation of radiographic parameters can aid surgeons determining when to add fusion to a planned decompression for degenerative listhesis. So in the next 2 slides, I'll summarize or discuss rather the summarizing recommendations and findings from these high quality or high impact papers. From the 3 RCTs, they each report similar results in terms of ODI outcomes. There was no difference at final follow-up between decompression and fusion and decompression alone across any of the studies. The North American or SLIP trial used SF36 as its primary outcome measure and reported better improvement in the fusion group, but SF36 was not commonly used in the European RCTs, the Scandinavian ones. The studies do differ in their reporting of the index level reoperation rates. The SLIP and the Nordsten trials report higher reoperation rates in the decompression alone. The Swedish study reported no difference. And indeed, surgical techniques were not standardized across the studies, with a variable use of midline sparing decompressive techniques, which confounds some of the comparisons. Again, remember, all these were published in the New England Journal of Medicine. How about the 2 meta-analyses? They also include some contradictory conclusions, but the magnitude of functional improvement was reported to be higher in those who had undergone decompression with fusion. Now, given the mixed results of these recent RCTs and meta-analyses, there's no an all-encompassing single conclusion regarding the efficacy of one surgical technique versus the other. It is clear that decompression alone is appropriate in many patients. It is equally clear that there is a subset of patients with listhesis in whom decompression alone would probably lead to instability or enhance disability and thus reoperation. Again, we need to recognize caveats. Are randomized controlled trials providing conclusions which are representative in all healthcare systems? Are there limiting or influential factors in the socialized healthcare system of the European trials, where there was a fixed salary, versus the setting of RCTs in the North American, where doctors have fee for service? And finally, when we consider inclusion and exclusion criteria, how representative do they render the RCT setup with respect to everyday practice? So to summarize everything, both decompression alone and decompression with fusion can be considered in the surgical management of degenerative lumbar spondylolisthesis. Precisely determining what patients require decompression alone or decompression plus fusion is not yet fully clarified. I would argue that instability continues to be the elusive term to many people, and it's a source of confusion. Possible clinical and radiographic parameters for evaluating this risk have been proposed, but there has been no definitive proof and no definitive RCT assessments, to my knowledge. And again, future research will have to shed light on specific patient, specific imaging, and specific technical factors as to postoperative instability, so that hopefully in the future we can choose to offer fusions in those where the additional risk and the additional morbidity is justified. So thank you for your attention. I would like to acknowledge the AO Knowledge Forum Degenerative and Christopher Martin in particular from Minnesota. And I'll stop there. Thank you again.
Thank you, Andreas. I think brilliant talk. Enjoyed that. I think nearly everybody is saying the same thing, that we don't have enough evidence out there. And unfortunately, despite knowing what we need to do, we haven't done that over the years. But that's how doctors are. Anyway, I think, and we look at the results depending on, if you're a surgeon, if you're a physiotherapist, or if you are, somebody else. So everybody looks at their own perspective. There's a question from Dr. Harshad Parekh, and he's asking, what's your recommendation for fusion versus non-fusion if there's no instability on radiology but listhesis?
Yeah, so exactly. So what is the actual practice? In my practice, if someone is elderly and there's only a grade 1 slip without dynamic instability, I will do a decompression alone. If there is instability of 4 millimeters or more, if there's a high disc, and if there's again that facet orientation that worries me, I will have to think twice. But to keep things simple, if there's no dynamic instability, if it's grade 1, and especially in the elderly, there is plenty of evidence to let us do a decompression alone.
Sandeep, you want to take this question, please?
Yeah. So in my practice, we have gradually moved away from fusing almost, like, I'll not say everybody, but our fusion rate was almost 80% in degenerative spine. And now gradually we have moved away from it, and more often we are doing just decompression alone. So I was just looking at the data of last 5 years. So we had done 1,600 decompression alone for canal stenosis and grade 1 listhesis, as compared to less than, I think less than 300 fusions. So previously it was just the reverse. It's 8-9 years ago. So gradually we are moving away from fusions to decompression alone. And we have had pretty good results, and our reoperation rate is really low. But I must say that long-term satisfaction rates and pain rates were better in those patients who were decompression and fusion, as compared to some patients of decompression alone who continue to complain of pain, but their MRI doesn't suggest any need for reoperation. So the reoperation rate is low, but still some patients are not satisfied. So I'm still not 100% sure what to do in which patient. So we choose each patient independently.
I would agree. It's all about personalized care, and the treating physician who has the patient in front of them should be the best person to judge the pros and cons of either option. I see there a question about
dynamic fusion.
Yeah, dynamic fusion systems. Is there any convincing indication? Well, I do have some experience with the dynamic stabilization using the Cosmic system by Ulrich Medical, and taking a step back, it's fair to say that there are different types of dynamic fusion systems. Some of them are pedicle screw based, like the one I'm referring to, and others are the so-called interspinal spaces, which in my opinion, I think are now outdated. There's plenty of evidence that those do not stand the test of time. I think the only long-term trial data that I'm aware of for dynamic fusion systems is that in the end, they slowly fuse. The proposal was that they wouldn't fully fuse, that they would hold the segment together while maintaining some motion, but in the end, they also fuse. But they haven't really become very popular, and most people I know have stopped using them. So that's all I can comment on that.
Mehmet, you have any comment on that, on dynamic fusion?
No, really. We need still some studies, high-level studies, to confirm that they have benefits of fusion.
Okay.
I would say just one thing in favor of decompression alone is that a lot of patients, particularly I'm talking about older populations, patient in their late 80s and early 90s, who are not really a very fit candidate for big surgeries. They are now coming forward to get operated. Otherwise, they would be scared of doing bigger surgeries. So we are operating a lot of patients in their 80s now.
Obviously, they're already fused, so majority of the time you don't need to worry about fusion there. So at that age, they are already fixed fused.
I agree with Salman and Sandeep that with age we get stiffness, and they may not be classically fused, but they are as good as. And the compression alone is usually more than enough, unless there is overt instability. And going back to the word instability, this is the confusing term, right? I mean, what is instability means is explained in many different ways to very different people. So I think in the elderly, there's plenty of evidence now, even if we accept or not the RCTs, there's plenty of evidence that the compression alone for grade 1 is fine.
Okay, so at least we have consensus on that. We all agree on that. That's good. Any more comment, Sandeep?
I'm just checking if there are any questions.
Dr. Parekh is also asking a question about facetal screws as suggested by Atul Goel.
I don't have experience of facetal screws, to be honest. I haven't used them. If I'm worried about true instability, I will use pedicle screws. I don't have experience of facet screws, to be honest. Do you guys, maybe you can shed light on that if you have experience with that.
Mehmet?
I think the facetal screws are weaker in construct, and they should not be primarily used in especially in lumbar spine.
Okay. Andreas, thank you. It was really nice of you to be here, and
Thank you so much. Pleasure.
okay.